All right, let's dive into a structured, exam-focused review of Marburg virus disease. We're going to cover the really high-yield concepts, from the fundamental virology and pathogenesis all the way through to clinical signs, diagnosis, and the principles of management. So we've broken this down into 6 key sections. We'll start with the basics and then build up logically to the clinical application. First up, let's start with a solid definition of the disease and get a handle on its core epidemiological features. So what exactly is Marburg virus disease, or MVD? It's a severe viral hemorrhagic fever caused by the Marburg virus. And as a member of the Filoviridae family, it's a very close relative of the Ebola virus, sharing a lot of clinical and structural features. It actually got its name back in 1967 following simultaneous outbreaks in Marburg, Germany, and Belgrade, Serbia. Now, here's a number that really drives home how serious this is. The case fatality rate has reached as high as 88% in some outbreaks. It does vary, from 24% on the lower end, and that difference often comes down to the specific virus strain and, critically, the quality of supportive care that patients receive. Understanding the chain of transmission is absolutely vital. So where does it come from? The natural reservoir is the Rusetus aegypticus fruit bat. The jump to humans usually happens after someone has had prolonged exposure to bat colonies, say in a mine or a cave. After that, it spreads from person to person through direct contact with blood, secretions, or other bodily fluids. This, of course, creates a huge risk for healthcare settings. Okay, now let's zoom in a little bit on the virus itself. We need to understand its structure to really appreciate how it causes disease. Marburg virus, or MARV, is an enveloped, filamentous, or thread-like virion. As we said, it belongs to the Filoviridae family. Its genetic material is a single-stranded, negative-sense RNA genome about 19 kilobases long. And this genome contains the code for 7 essential proteins that are just critical for the virus to replicate and cause disease. Now, several of these proteins are key players in Marburg's virulence. The glycoprotein, GP, is like the virus's key. It's what lets it into the host cell. But once inside, VP35 and VP24 get to work on immune evasion. They actively fight the host's interferon response, which is a major part of our innate antiviral defense. Meanwhile, the VP40 protein manages the assembly of new virus particles, and the L polymerase gets busy copying the viral genome. So this brings us to the big question. How does Marburg virus infection actually lead to such severe systemic illness? Let's walk through that step-by-step process. The pathogenesis of MVD really unfolds in this devastating cascade. The virus starts by targeting key immune cells, especially macrophages and dendritic cells. This attack messes with antigen presentation and causes widespread T lymphocyte death, leading to a state of profound immunosuppression. But then, the immune response that is mounted becomes completely dysregulated, triggering a cytokine storm, this massive, uncontrolled release of pro-inflammatory signals. That's what causes the systemic inflammation, damages the blood vessels, and leads to the hemorrhage, shock, and ultimately multi-organ failure. And here's a critical distinction, especially for exams. You have to understand the mechanism of shock here. In MVD, the shock is driven by the host's own haywire immune response, that cytokine storm causing the vessels to become leaky. This is fundamentally different from the shock in bacterial sepsis, which is typically driven by molecules from the pathogen itself, like endotoxins. All right, let's switch gears to the clinic. Understanding this clinical progression is absolutely key to early suspicion and diagnosis, which can make all the difference. The clinical course of MVD tends to move through these distinct phases. After an incubation period, which can be anywhere from 2 to 21 days, the patient gets hit with this abrupt onset of very nonspecific symptoms: high fever, headache, muscle aches. But around day 5, things progress. You start to see a maculopapular rash, severe GI symptoms, and the beginning of those classic hemorrhagic signs. From there, in the late organ phase, the patient either starts a slow recovery or deteriorates into shock and multi-organ failure. Death, when it occurs, is typically between days 8 and 9 of the illness. And while those first outbreaks were in Europe, MVD is primarily a disease of sub-Saharan Africa. The recent outbreaks in 2023 in both Equatorial Guinea and Tanzania are a stark reminder that this is still a very real and ongoing public health threat. Okay, so you have a suspected case. How do you actually confirm the diagnosis? Let's move on to the lab methods. For diagnosing an active MVD infection, the gold standard, without a doubt, is RT-PCR. It detects viral RNA, and it's both highly sensitive and specific. Now, there are other methods like antigen capture tests or ELISIS to look for antibodies, but for that acute diagnosis, RT-PCR is the one you need to know. Virus isolation is technically possible, but it requires the absolute highest level of biocontainment.
And I really cannot stress this enough. Specimen handling requires the most stringent safety protocols imaginable. All patient samples are considered extremely biohazardous and must be processed under maximum containment conditions in what's known as a Biosafety Level 4 or BSL-4 lab.
So besides just finding the virus, the other lab results paint a pretty clear picture of the systemic damage. You'll typically see thrombocytopenia, a low platelet count, and leukopenia, a low white blood cell count, very early on. This is followed by a dramatic spike in liver enzymes, AST and ALT, which points to severe hepatitis. Evidence of DIC is also very common. Finally, let's talk about the clinical response. What can we do for patients, and just as importantly, how do we control the spread during an outbreak? Here's the difficult reality. As of right now, we have no licensed vaccines and no specific antiviral treatments for MVD. That means patient survival depends entirely on aggressive, supportive care. The absolute cornerstone of that care is managing the profound fluid loss and shock with intravenous fluids, while also treating symptoms and keeping electrolytes balanced. Breaking that chain of transmission is everything, and this requires a really robust public health response focused on strict infection prevention and control. The key interventions are rapid identification and isolation of cases, meticulous use of PPE by all healthcare workers, making sure burial practices are safe and dignified, and having strong community engagement. Okay, let's quickly summarize for your exams. These are the high-yield facts you need to have locked in. It's a filovirus, just like Ebola. The reservoir is the Egyptian fruit bat. The pathogenesis is all about that cytokine storm and endothelial dysfunction. The hallmark signs are hemorrhagic fever and shock. Diagnosis, RT-PCR is the gold standard. Containment, it requires BSL-4. And treatment, it's all about aggressive supportive care. So what's the crucial takeaway here? It's this. Marburg virus disease is a severe hemorrhagic fever where the primary driver of death is shock from the body's own immune dysregulation. In that context, a rapid diagnosis using RT-PCR and immediate, aggressive supportive management are the most essential tools we have to improve patient outcomes and control these devastating outbreaks.